Hi and welcome. I'm Vicki Shaw with Clinical Liver Disease Journal, and I'm here today with Dr. Sanjeev Arora at University of New Mexico. He's here to discuss his article about novel models for hepatitis C delivery of care. Thank you for joining us today, Dr. Arora. So can you first talk about the barriers of telemedicine?
So telemedicine means many things to many people, but traditional telemedicine is one specialist helping a patient remotely. It is extraordinarily beneficial in the sense that patients don't have to travel for care. The primary reason that telemedicine has not been widely adopted in the world is that there is an overall shortage of specialist time. So specialists are quite busy taking care of patients in cities. And they are somewhat reluctant to take time off, come in front of a camera and see a patient in a remote area. Also, when that happens, sometimes telemedicine is not as efficient as them seeing patients in their local office. And they already have long waits for patients to see them in their office. In addition, there isn't enough reimbursement for specialists to spend time on telemedicine. And for these reasons, even though telemedicine is an extraordinary intervention, it has not been adopted as widely as it should be around the world.
Yeah. So can you describe your ECHO program and how it works?
So the ECHO program is somewhat different from traditional telemedicine in that our goal is not directly to treat a patient who's sitting remotely. Our goal is to train primary care clinicians to become experts so that they themselves can treat patients in their local communities and patients don't have to travel. The goal of ECHO is force multiplication, is to exponentially improve the capacity to deliver best practice care in rural areas. And we do this through a process called the ECHO model, which is based on 4 ideas. First, to use technology to leverage the expertise of a multidisciplinary team of experts. Second, we share best practices. But we know that just sharing best practices doesn't get primary care clinicians to treat a complex disease like hepatitis C. So the third part of the model is what we call case-based learning, in which 25 primary care clinicians join together on an interactive video network and present cases to each other in a de-identified way. And so each primary care clinician gets to learn on their own patients, but learn on everybody else's patients at the same time. We call this all teach, all learn. And over the course of a year, they become experts and don't need the specialists anymore to treat hepatitis C. What this does finally is that it expands the capacity to treat hepatitis C 10 times or more, and therefore waits for patients go down and patients can get care within their local communities.
So with the ECHO program, how have this model been able to help with delivering care for hepatitis C?
So we started ECHO in New Mexico, and there was an 8-month wait to see me. People would have to drive hundreds of miles to see me, and of the 28,000 patients that had been diagnosed, less than 5% had been treated. What we did is we started training these primary care clinicians and prison providers, and we have trained about 35 such sites now. The wait in my clinic fell from 8 months to 2 weeks. We treat as many as a couple of thousand patients every year now. All over the state, patients don't have to travel, and we have shown in our studies that the cure rates are exactly the same as if they got care from specialists.
That's wonderful.
And the project now has been replicated in 51 separate networks around the world in 38 countries for treating hepatitis C. And in the US alone, we have close to 30 networks treating hepatitis C here, with thousands and thousands of primary care clinicians participating and hundreds of thousands of patients who have been treated.
This is wonderful. Thank you so much for joining us today.
Thank you for the opportunity, Dr. Shah.
Thank you.